ಅವಾಗ ಬೇಡ.
You are the host now, sir.
Yeah,
You can start.
sharing my screen. Yeah, I think my screen is visible now.
Yes,
Yes,
sir.
Yes. Yeah. Okay.
Yes, sir. Yes, sir.
I think we could start now. Hi, I'm Dr. Madhan here from Pondicherry. Happy New Year. It's a Tamil New Year. So we will discuss about how exactly we go about scanning for any carpal tunnel patient and probably looking for the possible interventions. So before we actually enter into what we are going to do for the patient, we need to understand how exactly the carpal tunnel looks like. Most of the times, I do see a lot of people actually posting on social media without the visualization of the carpal bones. Ideally, you should be able to see the carpal bones. Then only that's the right place to actually do the scanning and intervention where we see the retinaculum and the structures outside, that is the ulnar artery and the ulnar nerve, and the structures within the carpal tunnel. So I'm not getting into the details. Only the structures within the carpal tunnel we need to know: the 9 tendons, the flexor tendons, the median nerve, and the retinaculum. So other things we will not discuss right now. So the dissection anatomy. Most of the times we end up actually putting in a needle through the retinaculum, which is this wide actually. How wide is this actually? And you could see the structure which is going in. That's the yellow one. That's the median nerve. And the retinaculum is so wide actually that the proximal distal length of the retinaculum is around, average is around 3 centimeters. It's around 3 centimeters. I'm not very sure how many of you have really given anesthesia or assisted for a carpal tunnel release, a surgical release. This is the released retinaculum. This is the released retinaculum. Such a wide proximal distal length of the flexor retinaculum needs to be mentioned here because we as interventionists put in just one needle and inject, and we expect enormous results. Probably we may not be able to get unless we choose the right patient for their intervention. And these are the median branch nerves, the branches. So how exactly the pain presents is: on the palm of the hand, it is the 3.5 fingers on the radial side. On the front of the hand, that's the dorsum. It is around the interphalangeal joints, the proximal interphalangeal joints, and more distally. The symptoms would range from numbness, tingling, feeling of pins and needles, reduced sensitivity, growing weakness, eighth thumb deformity, difficulty feeling in the fingertips, and sometimes a reduced hand dexterity. So these are the possible symptoms of carpal tunnel syndrome, and these are the signs. These are the signs which we need to elicit. I think I request everyone to. I request everyone to please mute yourself, please. Yes, thank you. Yeah. So we can do the Tinel sign, Tinel's test, the Phalanx test, the Tocant's test, and the reverse Phalanx test. All these are clinical tests which we need to perform prior to doing any diagnosis or intervention. Am I audible?
Yes, sir,
Yes,
you're
sir.
audible.
Just
Screen
one
is
moment. Yes. Now, lot of times we do have a problem with interpretation of the neurodiagnostic studies. We do have a clinical suspicion of carpal tunnel syndrome. This is the patient who actually deserves an electrodiagnostic study. Unless you have a significant suspicion of a clinical carpal tunnel syndrome, do not ever go for an electrodiagnostic study. In electrodiagnostic study, if you have a sensory or a motor or a combination of both, then you go for testing the ulnar nerve. If ulnar nerve is normal, then it is considered as carpal tunnel syndrome. If the ulnar nerve is also involved, then consider peripheral neuropathy. Simple. If it is only median nerve, consider it is carpal tunnel syndrome. If it is a combination of median nerve and ulnar nerve, consider peripheral neuropathy and evaluate other causes. Then, if it is either sensory or motor, you could keep on doing the palmar mix on the ring or the thumb fingers, then do the inching method, then exclude or include if it is a case of carpal tunnel syndrome. Basically, even though the neurologist does this, you need to understand that if it is only the median nerve which is involved, then call it a carpal tunnel syndrome. Otherwise, it is a case of peripheral neuropathy. Please do not do any intervention. So what is the etiology? Most of the times it's given as a idiopathic syndrome, but it is hardly less than 10%. Most of your patients are going to have an underlying cause. Unless you treat this underlying cause, you are not going to end up doing a proper intervention, or the pain relief won't be adequate. So hypothyroids, diabetes, a persistent median artery, bifid or trifid nerve, amyloidosis, pregnancy, occupational disorders like patients who actually are electricians, plumbers, do get a lot of patients with carpal tunnel syndrome. And obviously you have the intra-articular ganglia or tenosynovitis of the flexor tendons. All these are the etiologies. And this is how the presentation is. The pain, which could be significant in the night, numbness, paresthesia, sometimes the ape thumb deformity because of the wasting of the nerve muscles, and there can be a local edema, which is not very common. So what is the role of ultrasound for diagnosis? Earlier, we actually were not doing an ultrasound study at all. Now, with the advent of ultrasound study, we tend to overdo it. So when actually is it really required? Any patient who is having a night pain, any patient who is having a numbness of the both the means like the radial 3.5 fingers, they deserve an ultrasound study. Before any progressive demyelination or fibrosclerosis on histology occurs, you tend to get changes on ultrasound, which is changes in the caliber and ecotexture before any progressive demyelination or fibrosclerosis. So by far, immediately after the symptom presents, it is only the ultrasound which has to be done as the first investigation, then refer the patient for an electrodiagnostic study, both of which has to be done prior to deciding it is a carpal tunnel syndrome and then doing an intervention. So what is the potential, the diagnostic potential? Any difference of more than 2.5 millimeters square. This study was done in Saudi Arabia. Anything more than 2.5 millimeters square is considered as significant, and this shows the importance of ultrasound in early carpal tunnel syndrome patients. So this can actually alleviate permanent nerve damage and functional disability. So always this should be an investigation number one. So there is now sufficient evidence to propose there is a new paradigm for the diagnosis of ultrasound in diagnosis of carpal tunnel syndrome, and it is in similar with neurodiagnostic studies, both in terms of similarity and specificity. So ultrasound has to be included into the diagnosis of carpal tunnel syndrome. So what is the value of ultrasound? There are many studies, 344 patients being evaluated, and it's an effective method in studying the morphology of the tunnel and the compressed nerve rather than doing only the conduction study by neurodiagnostic studies. How do you do the examination? This area is more prone for anisotropy, and most of the times I have seen patients being examined more proximally rather than actually including the carpal bones for examination. Keep an IV bottle under the wrist, and you could actually give a small little bottle here so that the patient will be able to move the fingers to actually negate any kind of anisotropy which might be there while examination. Right? This is the best ergonomics. Always keep the patient from the side, either for the scanning or for the intervention. then the machine, you should be actually facing the machine. You don't have any problems with turning the neck and seeing the machine. You should always keep the patient in between the interventionist and the scan machine. So what are the findings you are actually going to look for? You know that you will see the changes in the shape and the echo texture. You could see a swollen nerve or a flattened nerve, which is either called a notch sign, which is proximal, and inverted notch sign, which is distal. There can be a persistent median artery, a bifid or a trifid median nerve. There can be an abnormality of the transverse carpal ligament. There can be an increase in the thickening, particularly in hypothyroids and pregnant patients. And always examine the structures within the tunnel for a ganglia or a tenosynovitis. At the time of examination of a carpal tunnel, you should see the carpal bones. This is the scaphoid tubercle above which you have the tendon of FCR, and this is the pisiform, and you could see the ulnar artery and the ulnar nerve just outside. And these are the tendons, the 9 tendons, and that's the median nerve. And the retinaculum should be seen here, extending from the pisiform to the scaphoid, so that you will get a proper turtle-like appearance. So that is exactly called, means that's the optimal examination of the carpal tunnel. Unless you see these bones and the carpal bones here below, you are not in the right plane for examination of the carpal tunnel. One more very important thing, again, you could see the bifid nerve, you could see the pisiform, and when you examine here, you could see a small little branch, that's the palmar cutaneous branch there. That is one branch which is prone for injury either during the surgery or during the intervention when you do a needling from the radial side. Again, playing it again for you.
Hello, Madan
Just
sir.
one. Yeah, I'm there. Am I audible?
Sir, you are audible, sir. I think a few candidates are in the waiting room, sir. If you could just admit them.
Yeah, just one moment. Yeah, admitted all of them.
Thank you, sir.
Yeah. Okay, you could see that's a small little branch, that's a palmar cutaneous branch, which can get injured at the time of surgical release or at the time of intervention. Particularly prone for injury when you are doing a radial side needling, so that you tend to do only the medial side needling. So this is the surface area which you need to see. That's the surface area. You could see the curved surface area. It's around 21.35. Normal is 9 millimeters square. If it is more than 14 millimeters square, it's called carpal tunnel syndrome. So what are the findings which you see on ultrasound? On the long axis, you could see a hourglass-like appearance. That's the carpal ligament, the transverse carpal ligament, compressing the median nerve, and this is the proximal thickening of the nerve. Basically, it's not the thickening, it's basically the venous congestion. It's basically the venous congestion. I request all the delegates to please switch off your audio, please. Kindly mute your audio, please.
Kindly mute your audio, please.
Kindly mute your audio, all the delegates.
Dr. Karthikeyan A. Kindly mute your audio.
Yeah.
Thank
Okay. Right.
You can start, sir.
Yeah, I'll start. Right. So this is the typical hourglass appearance. There is a long end of, means like this is the proximal end and this is the distal end. Both sides you've got the notch sign and the inverse notch sign in the same patient. There is a long segment of the nerve which is narrowed down. Okay. There is an abrupt change in the caliber at the entrance of the carpal tunnel. That's called the notch sign. The same thing happens at the exit. It's called the inverse notch. And anything more than 14 millimeters square, it's called the carpal tunnel syndrome. So somomorphologically, there are many other criteria, but please do not remember everything. Just remember only one thing, which is more than 14 millimeters square at the distal carpal tunnel. It's indicative of a carpal tunnel syndrome. So what are all the other findings which you want to see? The loss of fascicular pattern. As all of us anesthetists, we know that there will be a fascicle. A lot of fascicles can be seen in a normal nerve, which will be lost. There can be an intraneural edema and fibrosis. Hyperemia can be there. One vessel within the median nerve is a normal finding, but many arteries pulsatile within the nerve actually is abnormal. There can be a reverse sliding when you do the flexion and extension of the fingers. There is an increase in the convexity of the carpal ligament if there is a thickened nerve. And there can be a increase in the thickness of the transverse carpal ligament. More than 2 millimeters is significant. Tenosynovitis and ganglia associated with the flexor tendons also need to be ruled out. There can be an accessory muscle like this. This is the median nerve, which is flat. And within the carpal tunnel, there is an accessory muscle that is the FDS belly. So all these muscles need not be just the tendons. There can be a more distal insertion of the muscle itself. So when you retract it surgically, you could see the thickened and flattened nerve. So ideally, it is not just a idiopathic syndrome at all. You could see this. See, this is the bifid nerve, and one patient which you could see there is the 4 divisions of the nerve, quadrifoot nerve, which is not documented in literature. And post-op retinaculum, when you do a scan, it can be a wavy appearance. And early recurrence and the late recurrence is possible even after surgery. So what are the possibilities? That it can be an incomplete release or the scarring of the nerve itself. So how exactly do you go about? Always do not flout any sterile precautions. Always try to use a small needle. 23 or a 26 gauge needle, 1.5 inches is required. And this is a palmar side needling. I've kept a bottle underneath. The entire limb is draped properly. And
అడకలో okay.
what I want to discuss here is this entire thickness which got actually released here. This is the flexor retinaculum. This is around say 3 centimeters in proximo-distal length actually. So this is not whatever needle fenestration which you are doing before or after the procedure may not be sufficient because it is only that drug which you are actually. Can somebody please stop talking here?
Kindly mute yourself.
Please.
Please mute yourself.
Please. Okay, and this exactly is like you could do a scaphoid side, that is radial side needling, or you could do a palmar side needling, that is pisiform side needling. Either of which can be done, but personally I prefer if you actually get in your needle from the medial side, you actually may not end up hitting the pisiform. But when you actually come from the scaphoid side, that is the radial side, you may end up either hitting the palmar cutaneous branch, number one. Number two, the needle might closely be coming or maybe through the flexor, means like that is the FCR tendon. And thirdly, you might actually hit the scaphoid and more steep needling is required. Your needle may not be seen properly. The needle tip and the needle shaft may not be seen fully, right? Then again, in the needling, you can do a long axis needling either from proximal to distal or distal to proximal. I prefer doing it distal to proximal because the results are better. Only problem is that because of the obliquity of the needle, this can be very straight and this will be a slightly oblique needle. There will be some amount of anisotropy at the time of imaging and needling. So there can be other things which are also possible to be given. It's like you could do a injection of steroid. You could do a injection of Botox. All these are giving short-term results, but long-term results are better given with 5% dextrose. Right? So this is actually like there are plenty of studies to say that 5% dextrose improves the rate of recovery. In 88% patients, actually, the effective income was noted, and there are only some 11.4% of patients who have actually reported as poor, and that is after 2.2 injections. That is, average of 2 to 3 injections will be required, 5% dextrose every 4 weeks. And after 1 to 3 years of injection of follow-up, this is the actual report. So nearly 90% results is something very, very, very significant. I always tell, please do not go in for intervention when there is a motor means weakness. Please don't go in for an intervention if there is any severe carpal tunnel syndrome as per documented by the neurodiagnostic studies. Always mild to moderate cases, patients who do not have an apthum deformity, no motor weakness, and patients who really means like they don't have any other comorbidities, means like there is no ganglion, there is no tenosynovitis, then these are the patients who qualify for a 5% dextrose injection, right? Plenty of studies out there. And PRPs again, it's coming up, means they say that it is more effective than conservative treatment. There is no comparison with your 5% dextrose. And Botox, again, this study was done, means like the follow was after 12 weeks. I think this was done by Dr. Abdullah, actually. This was actually an injection, not into the tendon, not into the tunnel. This was given just at the myotendinous junction of the flexor tendons. And this also has given better results, significant improvements even in the electrophysiological study, but not a major study. So things are yet to evolve on Botox. This is a very important technique which all anesthetists, means like as pain physicians, background of anesthesia, must know. Maybe not put into practice is the Mayo Clinic technique. Put in a 2He needle, 18-gauge 2He needle under the retinaculum into the safe zone that is close to the ulnar artery and the ulnar nerve, and pass in a nylon thread here, check it back more distally, then loop it around the retinaculum by passing the needle above. So you have a loop formed around the retinaculum and then release it completely. So this is actually the released retinaculum. I personally have done 6. I have not landed with the problem, but I'm not the person who will comment on this unless this technique is actually put forward. Right? This is a mini invasive technique.
You're not audible, sir. Hello?
I mean,
Yeah, now yes, you're audible.
yeah, the take-home point is only one actually. Do not do interventions on all your patients. Reserve it only for mild to moderate cases without any motor deformity. Number 1. Number 2, Do not combine steroids and dextrose. Thirdly, dextrose acts better than your steroid. And PRP is always an emerging thing. It is actually not means like we have not we are not having any big trials actually to say that PRP is better than your 5% dextrose. And definitely the surgical release may be warranted for severe cases, which we shouldn't actually like stop referring to a surgeon. It's like we need to actually refer to the surgeon for severe cases. So it was means like carpal tunnel is one thing which is all of us know, like it is the commonest entrapment syndrome, which can be easily treated with ultrasound guided interventions. And it is only 5% exposed all the way for mild to moderate cases. Do not venture into giving for severe cases. Patients with numbness and motor weakness do not deserve a dextrose injection. Thank you so much.
Thank you very much, sir, for a wonderful, innovative presentation. We got to know a lot of new things in how to manage carpal tunnel syndrome. I would request you to stop sharing your screen, sir, and make me the host.
Yeah, I have.
Yes, thank you very much, sir. And we will be taking in the questions and everything after the completion of the second session. So,
Yeah, Javed, just a special request actually.
yes, sir.
I will be driving in another 5-10 minutes. So I'll just put it means like switch it on my mobile actually,
No problem. No problem, sir.
and I'll answer the questions when driving. Okay.
Thank you. Thank you very much, sir.
Thank you. Thank you.
It was a wonderful presentation as usual. And now we will move on to the second session. For the candidates, what I would tell is you can always put in your questions within the message box as well, chat box. And now I would like to invite our second esteemed guest, Dr. Pratibha Matche, ma'am. Madam is there with us.
Yes,
Hello, ma'am. A very good morning to you.
very good morning.
And it's always a wonderful feeling to have Madam in any of the activities, because I always tell that I started my pain medicine career with Madam only, and it's always a very nostalgic feeling to do any kind of educational activities and to have Madam along with me. So before we start, I'll just share my screen, Madam, once. Let me know once my screen. Yeah. My screen is visible.
Yeah.
So we have Dr. Pratibha Matche, madam, with us. Madam is the MBBS, DA, DNB, FIAPM, and CCPC. Madam is the head of Pain and Palliative Care Unit, Department of Anesthesiology, JSS Medical College, JSS Academy of Higher Education, Mysuru, Karnataka. Madam did her MBBS from BJ Medical College, Pune, and post-graduation from TN Medical College, Mumbai. Madam is the president of IASP Karnataka chapter. Madam was the first to start a pain clinic in a medical college in the state of Karnataka in the year 2009. She is the program head and mentor for IAPM affiliated as well as JSS Academy fellowships in pain medicine at JSS Medical College and Hospital. Madam is the coordinator of CCAPC course by IAPC, that is the Indian Association of Palliative Care. Madam was the past acting registrar of Indian Academy of Pain Medicine. Madam won the Best Low-Cost Pain Treatment Award at the National Pain Conference. She has several publications in reputed journal and contributed book chapters. And Madam is always an invited faculty to almost all of the state and national pain conferences. I extend a warm thank you, ma'am, for accepting the invitation to be our esteemed guest and faculty for today. And I think I'll make you the host, ma'am.
Yeah, sure. Thank you so much for that very nice introduction, Javed. And it is always a pleasure to contribute to whatever you do.
Thank you. Thank you very much, ma'am.
I'm not able to share my screen.
I'm making you the host now, ma'am.
Yeah, sure.
1 second. Ma'am, and in between, there will be candidates joining in. So I would request you to admit them whenever.
Okay, so you can make yourself co-host also, Javed.
The setting, I think I have
Okay,
to
fine, no
setting
problem.
with some time. So if in between they come, just have to press the
Sure,
admit
sure,
button.
sure.
And I would request everybody else to mute yourselves so that we have
Yeah,
less
that's very important. Everybody,
interaction.
please mute yourself, because otherwise it is really,
Yeah, we have to keep saying. Mute
yeah,
yourself.
it's not a nice thing to keep telling that mute yourself.
Ma'am, you are the
So have
host.
you made me? Yeah.
Yes, you are the host now. Please share your screen once more.
Can you see my screen?
Yes, ma'am, we can see your screen. Please make it full screen, ma'am. Yes, it is full screen. We can start.
Okay, so I'm going to start with my topic, that is shoulder pain evaluation and diagnosis. And thank you so much, Javed, for that kind introduction. And it's always very happy and satisfying feeling for you to see grow so much right from the day one I have seen your journey, and it is phenomenal growth that I have seen in you. And you are kind of a role model for the youth. So very happy to be a part of your webinar. I'm going to start with my lecture, that is shoulder pain evaluation and diagnosis. That's my hospital where I work, JSS Medical College Hospital at Mysuru, Karnataka. And so we know that shoulder pain presents a unique challenge because of the biomechanical complexities, and it has an inherent instability of the shoulder girdle because of the good range of movement that is provided. And the differential diagnosis is expansive with so many causes, and the prevalence is anywhere from 16 to 26%. And it is the third most common causes of MSK pain, following the low back pain as well as the knee pain. So coming to the common causes of shoulder pain, we have the idiopathic causes like frozen shoulder, shoulder hand syndromes, degenerative pathologies, which we commonly come across as a pain physician, that is rotator cuff tendinopathy, calcific tendinitis, AC joint involvement, and the osteoarthritis of the shoulder joint, traumatic, inflammatory, metabolic, and malignancy. And shoulder pain can arise either directly from the structures forming the shoulder joint, or it can also get referred from the adjoining structures, which is very important to know. And the cause could be either traumatic, or it could be degenerative. It could be because secondary to the systemic diseases and infections. And shoulder pain is like a puzzle. So to solve the puzzle, we have to solve the puzzle, we have to go in a systematic manner, like follow the protocol, and only then you will be able to make a correct, accurate diagnosis. So you have to know the causes of shoulder pain, the intrinsic and extrinsic causes. The most common intrinsic causes are the rotator cuff pathology, the impingement syndrome, adhesive capsulitis, the involvement of AC joint, osteoarthritis, and so on. And the extrinsic causes mainly arising from the cervical region, the thoracic outlet syndrome can also cause referred pain. It could be malignancy and referred pain from the neck, chest, and heart. So you have to always rule out the red flags. And most common presenting symptoms that we come across in patients is the pain along with stiffness of the joint, decrease in the range of movement, weakness, the paresthesia or numbness will be present. And the most striking presentation that the shoulder pain patients come with is the limitation of daily activities, like they are not able to comb their hair, they are not able to put the bra strap or cook or hold something. So this is very, very disabling for them when they are not able to do the daily activities. There can be a pain at night and pain associated with specific activities. So in the history, we just have to see that we have to go into the details of pain history and give importance to all these things that I have written, and we are going to go one by one. So pain history is something which is very, very important, and we have to take I think only pain physicians go into the details of pain history so much. So we know the PQRST. So we always see that in case of shoulder pain, the onset is mostly insidious, but in certain conditions, it can be sudden pain, which could be calcific tendinitis, trauma, acute infections, and acute exacerbation of inflammatory disorders. The duration, it will help you to differentiate between the acute and chronic etiology. History of night pain can be suggestive of impingement and malignancy, and always ask for the history of radiation. If the pain is radiating from shoulder, arm, forearm down to the fingers, it is suggestive of cervical disc prolapse. Another important thing that you need to remember is if there is a case of left shoulder pain and cardiac pain, both would radiate to the left arm. Here, in this case, you always have to ask for the history of associated symptoms like chest pain, palpitations, breathlessness, or sweating. This will rule out the anginal pain, and it is very, very crucial, and it is an emergency. So coming to next, the character of pain, that is dull aching pain would be originating from the musculotendinous or ligamentous structure, and sharp burning or shooting kind of pain, which is suggestive of the neuropathic origin. Aggravating factors are very important to come to conclusion or give a clue to the diagnosis. Any pain on overhead activities is suggestive of rotator cuff tears or impingement. Pain on abduction, especially between the 60 to 120-degree abduction, which is called as a painful arc, is suggestive of the supraspinatus tendinitis. And pain on reaching like cross body, across the body, or beyond 120-degree to 180-degree, that is suggestive of the involvement of AC joint. Now, in addition to the history, you also have to pay attention to the location of pain. So if the patient says that the pain is in the, can you please mute yourself? Please mute yourself. So if the pain is in the lateral aspect of shoulder, then it is mostly suggestive of the rotator cuff lesions. If it is the patient is pointing anteriorly, then it is involvement of the biceps tendinopathy. Superiorly, it is AC joint involvement, and posteriorly, anywhere along the upper, the trapezius or interscapular region, could be because of the myofascial region. In addition to the pain history, the another important thing that is to be paid attention and evaluated is the involvement of the loss of range of movements. If the patient says that there is both active and passive loss of range of movements, then it is because of the adhesive capsulitis and the osteoarthritis. Whereas if only loss of active range of movement is there, then it is suggestive of rotator cuff pathology. So after the details of the pain history, just see when the patient is come to you, what age the patient belongs to. If it is a young patient, then mostly there could be dislocation, septic arthritis, and osteomyelitis. And middle-aged patients are most common. The reason in them is rotator cuff tendinopathy, tears, and calcific tendinitis. Whereas in elderly, you should have a high index of suspicion for a frozen shoulder, osteoarthritis, rheumatoid arthritis, and most importantly, secondaries from malignancy. So the history of occupation and sports is very, very important in shoulder pain. Patients who are involved into the lifting of heavy loads, or construction workers, or people who are involved into the overhead sports like tennis, they are at high risk of rotator cuff. Whereas people who are involved into the collision sports like football and hockey and in weightlifting, they are more prone for the instability and AC joint disorders. If there is history of trauma, always find out what is the mechanism of injury. If there is a fall on the outstretched hand, then there could be fracture and dislocation. And if there is a history of blunt trauma, then involvement of AC injuries is more common. And if there is history of whiplash injury, then the involvement of facet joint is common. Ask for the history of medical comorbidities like diabetes, thyroid, stroke, Parkinson's, and pulmonary diseases, because they are at high risk of frozen shoulder. Always rule out malignancy, MI, and the cervical spondylosis. Now, once we have gone into the details of history, the next thing comes is the physical examination. Please mute yourself.
Kindly mute yourself.
So the next one is the physical examination. So we have all learned during our MBBS days how to go for a systematic manner. And believe me, if you really do that, it is really going to give a clue to the diagnosis. So go for an inspection, palpation, look for the range of movement, do the strength testing, perform special provocative test wherever is required and whichever region it is involved, and do the other examination to rule out other etiologies. So as the patient is entering into your clinic, so just see how the patient is entering, what is his gait. Where most of the times, if there is a severe shoulder pain, then the patients will be coming with an elbow supported, the affected elbow is supported by the normal hand. And the shoulder pains have to be always examined properly disrobed because that will give a lot of information to you. And you just look for the scars, symmetry of both the shoulders, any evidence of swelling, any atrophy or hypertrophy of the muscles, and evidence of scapular winging. So look, if you see, if there is a bump in the area of the AC joint, then it could be because of the subluxation, dislocation, or osteoarthritis. If there is a swelling of biceps, then it could be a Popeye sign because of the rupture of the biceps tendon, winging of the scapula because of the paralysis of the serratus anterior, and atrophy of the supraspinatus or infraspinatus because of the rotator cuff tear or suprascapular neuropathy. So on palpation, look for the tenderness along the length of the clavicle, which could be seen in the sternoclavicular dislocations, tenderness at the AC joint and acromion in the SSD bursitis and RC lesions, and tenderness in the bicipital groove because of the bicipital pathology or tendinitis. And if there is a tenderness all around the joint, it is suggestive of osteoarthritis. So evaluate both active and passive range of movements. It's very, very important. And evaluate bilaterally for comparison. It's very important because sometimes it could be even in the normal limb, there could be restriction of the range of movements. Apply scratch test is one of the very good screening tests for the range of movements. Ask the patient, this is one of the simple tests. If you want to look for the range of movements, you just ask each and every patient to perform apply scratch test. Ask the patient to reach behind the head and touch the upper aspect of the opposite scapula. This will give you an idea about his external rotation and abduction. And ask him to reach behind the head and touch the lower aspect of the opposite scapula. This will help you to see his internal rotation and adduction. So next thing that comes is the special test. Once you have done the physical examination, the special tests are, there are too many special tests like tests for impingement, then rotator cuff tests, tests like drop arm, Job's empty can test, lift off test, and belly press test. For the biceps tendon, there is Speeds and Yergason test. For slap tear, O'Brien's test, and for instability, there are tests. So I'm not going to go into the details of the test, but you need to understand the sensitivity and specificity of the test. And you also have to correlate with the history, their examination, and the next I'm going to come to is the diagnostic blocks and the musculoskeletal. So it has to be an over view, this which will decide the diagnosis. You have to do the other examination, like examination of the cervical spine, the Adson's maneuver for the thoracic outlet syndrome, a thorough neurological evaluation, sensitimeter examination of the upper extremity, so that you can rule out the other causes. Now we'll come to the stepwise diagnostic clinical approach. So how do you stepwise diagnose a patient with the shoulder pain? So find out whether there is history of trauma or no. If there is no history of trauma and the cause is non-traumatic, then whether the cause is intrinsic or extrinsic. Once you have ruled out the extrinsic cause, in the intrinsic causes, whether it is glenohumeral or extraglenohumeral pathology. And once you have ruled out extraglenohumeral pathology, you differentiate the glenohumeral pathology. So we are going to go each step one by one. So first step is to determine whether the traumatic injury is present. Based on the patient's history and examination and simple plain X-rays, it may confirm the diagnosis. And if the X-ray fails to reveal an injury, there is normal X-ray, and patient still has persistence of symptoms, then think about the rotator cuff lesion. The second step is to determine whether the pathology is extrinsic or intrinsic. You have ruled out traumatic cause, and now it is atraumatic. And the second one is now whether it is the extrinsic or intrinsic cause. If the pain is because of the extrinsic cause, then most of the times the patient may not be able to localize the pain perfectly. They will have difficulty in localizing the pain. They will describe it as a vague pain, which is referred from thoracic and abdominal source. Or if it is a sharp with radiculopathy, then it could be a neurological source. And most important, on examination, you will find that there is no asymmetry, the strength is normal, and absolutely painless and normal range of movement is there if there is an extrinsic cause. So what are the different extrinsic causes? You could have pain because of the neural impingement due to disc herniation, which here the pain will always go down the elbow into the forearm, hand, and is accompanied by paresthesia. Peripheral nerve entrapment because of with the involvement of long thoracic and suprascapular nerve. The CRPS involving the upper arm and shoulder. Here you will have the triad of sensory, motor, and autonomic symptoms. And diaphragmatic irritation, intrathoracic tumors, and distension of the hepatic capsule can also produce ipsilateral shoulder pain. In case of MI, as we have already told, that the patient will complain of the sweating, dyspnea with each episode of my shoulder pain. So now, since we have already ruled out the extrinsic cause, then you know that now it is an intrinsic pathology. If it is intrinsic problem is present, determine whether it is glenohumeral or extraglenohumeral. Generally, if the patient is not able to localize the pain from extraglenohumeral pathology to a specific site, such as bicipital groove and AC joint. In all cases of extraglenohumeral pathology, the passive range of movement of shoulder joint will be normal. So patient will be able to localize the pain and the passive range of movement will be normal. So let us see the two important causes of extraglenohumeral causes. That is, if the patient has the tenderness in the bicipital groove, the Speed's test and Yergason test is positive, and the local anesthetic injection in the bicipital groove has relieved the pain, then definitely the etiology is, or the cause is arising from the bicipital tendon and mostly the bicipital tendinitis. So go for a therapeutic injection using local anesthetic with steroid under ultrasound guidance. The next cause is if the patient has tenderness in the AC joint, the scarf test and O'Brien's test is positive, and the cross-body adduction, if it increases the pain, then you think of the AC joint pathology. Get an X-ray, you may see some features of AC joint arthritis. So next is differentiating. Once the extraglenohumeral pathology has been ruled out, determine the causes of glenohumeral abnormalities. Assessment of range of movements, strength, and provocative test will help to diagnose the cause. Now coming to, this is little bit, you will have to pay attention to this to understand that how to differentiate between different glenohumeral causes. So if the patient comes with both active and passive range of movements which are restricted, you have also given the local anesthetic test, and in spite of that, the both active and passive range of movements are restricted, then go for an X-ray. If the X-ray is normal, then it could be adhesive capsulitis. Then go for a suprascapular nerve block, hydrodilatation, followed by physiotherapy. If the X-ray is showing some changes, maybe decrease in the space, the joint space, then it could be because of the glenohumeral osteoarthritis of the glenohumeral joint. Then either you can go for the radiofrequency ablation of the articular branches, or if it is very severe and patient is willing, then you could refer for replacement. Now, if the active range of movements are restricted, passive range of movements are normal or restricted, and weakness may or may not be present, but Neer's test and Hawkins test is positive, then it is suggestive of impingement. Now, empty cancer test is negative, drop arm test is negative, and weakness and pain both decreases after local anesthetic tests. Then do an MSK ultrasound, and it could be, depending on the findings, it could be either subacromial SASD bursitis or it could be rotator cuff tendinitis. Then once you have confirmed your diagnosis on ultrasound, you could go by for the therapeutic approach, that is either the local anesthetic with steroid injection or PRP injection. Now, if there is history of night pain, empty can sign is positive, external low rotation lag sign is positive, drop arm test is positive, and pain decreases after the local anesthetic, but weakness persists. This is very, very important. Pain will be decreased, but the weakness still persists after local anesthetic. This is suggestive of rotator cuff tear. So you could go and do the diagnosis on the ultrasound, if it is a good high resolution ultrasound, or MRI is a gold standard. It could be either a partial tear or full thickness tear. Then you can go for regenerative therapy, suprascapular nerve block followed by physiotherapy, or you can advise the repair if there is a full thickness tear. Now, this is the overview of the shoulder pain algorithm. Whenever the patient comes with a painful shoulder, find out whether it is traumatic, atraumatic, and if the red flags are present, you urgently refer the patient. If it is traumatic and history of well-localized pain, painful and restricted range of motion are there, and then weakness may or may not be present, you ask for an X-ray. If the X-ray is revealing the injury, then mostly it could be either fracture of the clavicle, or it could be a dislocation or AC split, and refer to an orthopedic. The X-ray is not, can you please mute yourself? If the X-ray doesn't show any injury, then evaluate for the intrinsic soft tissue injury. Now, once it is atraumatic cause, it could be either intrinsic or extrinsic causes. If there is history of poorly localized pain and normal strength and range of movements, then it is because of the extrinsic cause. Look for the extrinsic causes. If there is a pain which is localized to a specific site, passive range of movements are normal and active range of movement may or may not be restricted, then it is because of the extra glenohumeral cause, like from the AC joint or biceps tendon. If there is history of stiffness, restricted active range of movements, and restricted passive range of movements, which may or may not be there, then it is the glenohumeral causes. So we have followed the protocol. That is, we looked into the causes, we ruled out the red flags, we went into the details of the history, including the occupational history, age, then history of trauma, and how to look for the comorbidities. We looked for the special test to diagnose, and we have also, wherever required, investigations are also done, like an X-ray, MRI, or ultrasound. So now the next important thing or a tool for the diagnosis of shoulder pain as a pain physician for us is a diagnostic MSK ultrasound and the diagnostic interventions, which will give a very good clue for the shoulder pain. Ultrasound is definitely one of the useful diagnoses in the rotator cuff pathologies, the SSD bursitis, the biceps tendon pathology, the adhesive capsulitis. Almost many of the conditions could be diagnosed, and it is one of the accepted method of investigation for shoulder pathology. Most important thing about MSK ultrasound, which can't be done even with the MRI, is it allows the dynamic evaluation, which could be really valuable in few of the conditions. It is also quick, simple, and convenient. Most important, it is radiation free. It can be just diagnosed on the OPD basis. It allows the dynamic evaluation, which I have already told, and it will allow the accuracy and success of procedures. It determines the accuracy and success of procedures. So coming to the next diagnostic blocks, which could be used for the diagnosis, they can be performed to confirm the diagnosis of the rotator cuff tendinopathy, bicipital tendinitis, and the SASD bursitis. Patients with full thickness tear will have, like once you have given the local anesthetic test, this is one of the way to differentiate by the diagnostic block. If the patients with full thickness tear after local anesthetic, they have the relief of pain, but still there is a persistent weakness, then it could be because of the full thickness tear. And if there is a tendinopathy, then they will have normal strength with the pain relief after local anesthetics. And patients with frozen shoulder will have persistent loss of range of movements after the local anesthetic. So another few diagnostic blocks which could be used for other pathologies, like trigger point injection for myofascial pain, stellate ganglion block, and T2, T3 sympathetic block for CRPS, selective nerve root block for the radicular pain, suprascapular nerve block for the entrapment again, and local anesthetic injection for impingement. So to conclude, a thorough medical history, a good physical examination, the diagnostic MSK ultrasound, imaging studies, that is MRI, whenever required, and possibly the diagnostic injection which is a tool for us as a pain physician, will definitely allow you to accurately diagnose the specific cause of shoulder pain, and you can tailor make the treatment accordingly. So I really like this quote, that it is very important. It is more important to know what the patient the disease has rather than what disease the patient has. Thank you so much.
Thank you very much, ma'am, for a wonderful presentation. The shoulder pain is definitely a puzzle, and having the right diagnostic protocols is of utmost importance to diagnose our patients, as rightly said by you. And before you plan for any interventions, to get the right diagnosis is what is very, very vital. So I would request the participants to share questions in the chat box, and we'll start taking the questions one by one. I'll just reclaim the host, ma'am.
Yeah.
So one by one, we'll just start off with the questions. Madhan sir, you are there with us, sir?
Yeah, I'm there.
Okay, sir. So I'll ask the questions from the participants one by one. One question which has been asked is, do you come across patients who get back symptoms after surgical release of carpal tunnel syndrome? If yes, then how do you manage it?
So means like there is a failed surgery, right?
Yes.
See, failed surgery is more suited for a dextrose intervention because it is supposed to release the adhesions. That is the reason why we use dextrose for means perineural injection. So it is ideally suited, and I personally have done 2 cases, and it definitely relieves the pain because of a failed surgery. It is because of improper release or scarring around the nerve. So definitely it helps.
Sure, sir.
Yeah.
Next question, sir. What are the possible complications you get during the procedure? And please repeat the advantages of ulnar and radial side, which is better.
Yeah. See, the thing is, if you ask me like what are the complications of during the injection, yes, I will tell you. I have had a patient who has actually landed up with a vasovagal syncope. Actually, not syncope. She almost went into asystole. I'm not sure whether she really went into asystole. So always I advise you not to do the procedure in a sitting position. Always make the patient supine and see that the patient had enough of diet when they come for the procedure. Second thing is, means like the complications. Sometimes you may actually touch the nerve with your needle tip. So probably like there will be some tingling sensation at the time of needling. But definitely it has not landed up with any long-term symptoms of tingling. With respect to needling from the medial or the lateral side, I always prefer to give the advantage to the medial side needling, because comparing to the scaphoid and the pisiform is a lowly placed bone, so that the needling might be easier. The only problem is you might encounter the ulnar artery and the ulnar nerve, for which we should be careful enough. And if you are actually careful enough, you can reach the retinaculum without much collateral damage. Whereas if you do it on the radial side, there are 3 things which you need to encounter. One is the scaphoid tubercle, which is higher placed than the pisiform. Second one is the FCR tendon, which is placed right over the scaphoid tubercle. And third, very important structure with respect to either the intervention or the surgery, you can actually encounter the palmar cutaneous branch of the median nerve. That's again to be taken care of. So means like if you ask me, with an experience of say around more than nearly 500 carpal tunnels, I will say like it's only the medial side needling which is to be done rather than the radial side needling.
Perfect, sir. Perfect. Thank you very much for the explanation. The next question what we have is usually whenever we get the involvement of the median nerve, that is the carpal tunnel syndrome, what do you do if only motor symptoms are present or only sensory symptoms are present? How do you proceed?
See, thing is, I personally, I told you, there are ways, like, like you do a electrodiagnostic study. Don't read what is given at the bottom of the report. The bottom of the report will tell you mild, moderate, and severe. If there is a increased latency of sensory, that is probably the best patient who will respond to your intervention. Number one. Number two, if it is involving motor also and still qualifies under mild to moderate severity, definitely it will respond as well. But if the patient is having a motor weakness, an ape thumb deformity, ask the patient to oppose the thumb actually. Ask the patient to oppose the thumb. If the opponent is not fully acting, that's the patient which may not respond to your intervention in spite of doing it 2 to 3 times. Such patients must be referred only for a surgeon. Because a patient who is having a motor weakness, in spite of a surgery, they may take some 6 months for the recovery. So you really can't expect recovery with just one intervention or maybe 2 or 3 interventions. So definitely patients with motor block qualify for a surgery. Patients with sensory symptoms qualify for a intervention. So that's my thing. And if you go to the bottom of the report, mild to moderate cases will qualify for a intervention, and the severe, most severe cases will qualify for a surgery.
Right, sir. So
Okay.
the candidates want to know the ultrasound diagnostic criteria for carpal tunnel syndrome, sir.
See, there are plenty of criteria. At the outset, which I told you, is only follow one criteria, that is anything less than 9 millimeters square is considered as normal at the level of the distal carpal tunnel. At the level of the distal carpal tunnel, if it is exceeding 14 millimeters square, take it as a carpal tunnel syndrome. And there are many criteria. Means if you go through the literatures, nearly some 15, 16 criterions are available. But don't confuse yourself by just doing that. What I try to tell you is, don't look only at the measurement. There can be a normal measuring median nerve with symptoms because of tenosynovitis or a ganglion, and sometimes there will be an anomalous palmaris longus tendon within the carpal tunnel itself. So it is basically a study of the carpal tunnel by ultrasound rather than just looking only at the nerve. We are not concentrating on the median nerve here. We are looking at the tunnel as a whole. So going by the diagnostic criteria, again, it is only the CSA, that is the curved surface area, more than 14 millimeters square. If you really look at, like, you can examine some 10 centimeters proximal to the distal carpal tunnel. So there again, you can see and compare on the contralateral hand as well. So these are the things which we should do rather than just going by one value. As I told you, it should be a complementary to the electrodiagnostic studies. It cannot be taken as a single indicator for carpal tunnel syndrome, or it is equally specific and sensitive to the electrodiagnostic studies. That is also one thing which everyone should remember.
True, sir. Very true.
Okay.
Okay. Next question, sir. For patients who do not get immediate relief with dextrose, that is 5% dextrose, in such cases, what do we do, sir?
It's simple actually. The sensory symptoms are likely to continue for the next 1 month. Okay.
Correct.
So if the sensory symptoms are continuing, always ask them to wear the night splints. So do not ever assure everything with your intervention. So always ask them to wear a night splint even after the first or the second intervention. Number one. Number two, lifestyle modification, particularly the occupational modification, must be carried out when you are actually looking at a patient who is a plumber or an electrician who will do hard work. Okay. And thirdly, recently I went through one of the literatures by Paul Totland. Actually, he's from the United States. Actually, I think most of you must have probably his friends or something on LinkedIn. He advises you to go for 10 ml of 5% dextrose, add what he calls as a homeopathic dose of steroid. That is 1 milligram of dexamethasone or 0.1 ml of triamcinolone. Definitely that serves the purpose actually. That's what he has written, but we don't have a literature for that.
Okay, sure. Next question, sir, is how will you manage iatrogenic median nerve injury after nerve block?
It will not happen. If you are good enough, means like it will not happen.
If you're doing under ultrasound, definitely shouldn't be happening.
No, it is not the question of doing an ultrasound. No, like that's what I keep telling anyone. Do practice on yourself, because like the upper limb is one thing which everybody has to learn on yourself. First thing. Second thing is, at the time of needling, even if the needle tips sometimes touches the needle, touches the nerve, really nothing happens if it touches really. And don't worry about the needle tip just touching, actually, not a problem. It does not give rise to any long standing problems, no neuropraxia also. Don't worry about it.
Right. So next question, I would like to invite Dr. Pratibha ma'am. So, madam, you're there with us?
Yeah.
Yes, ma'am. So one question has come, ma'am.
Yes,
How
Javed.
to proceed with a labral tear in a post-stroke shoulder patient in an old age home where they are not even able to do an MRI? Shall I repeat it?
Labral tear?
Okay, they are asking,
Yeah.
there is a patient post-stroke and the patient is in an old age, patient is having a labral tear. So how to proceed? Because the patient, they're not able to do an MRI as well for this patient. So how to proceed with such patients, they are asking.
No, but if they have not done an MRI, then how they have
They know
diagnosed
the
in labral tear? Because without MRI, it is not possible to diagnose a labral tear.
correct.
And
Doctor, yes, ma'am, correct. Doctor,
definitely, I would like to suggest that we get a lot of patients in our PMR department who are patients with post-stroke patients who are suffering from the shoulder pain, as well as more than shoulder pain, it is the restriction of movements which are there. So rehabilitation is one very important thing. And if the patients are hospitalized, that is what we follow in our hospital. The protocol is we put a shoulder suprascapular catheter, because suprascapular block will, if you can even do a radio frequency ablation, or you can PRF, you can do, or you can put a catheter and then do the rehabilitation. So this supplies 70% of the shoulder joint, and you will definitely have a very good pain relief, and you can go for the rehabilitation. That will take care. And since it is an old patient, it is mainly for the palliative purpose, then it should help. But if you have known that the question is, I am not very clear, because if the MRI is not done, then the labral tear cannot be diagnosed.
now, ma'am, one more question is that, for example, if an MRI is done and there is a labral tear, how will the presentation be and how to diagnose if there is a labral tear?
Okay, so if patients with labral tear, it is a little confusing diagnosis and diagnosis of exclusion. Most of the times, the patient will have a dull aching type of a pain, which will be in the area of the biceps tendon. They will also have a clicky or catchy kind of a sensation, click kind of a pain, which will be felt by the patient. They will also have a weakness of the hand, and range of movements will be little affected. And definitely you will have to go for an MRI for the diagnosis of labral tear. So this is a diagnosis of exclusion when you have already ruled out all other causes and still it is not there, then you can go for an MRI and get the diagnosis done.
Yeah.
And the treatment would be, I would suggest that you should refer them to the orthopedician, and it could be an arthroscopic repair can be done.
Perfect. The next question, ma'am, is what should be looked in dynamic ultrasonography of shoulder? Dynamic ultrasound of shoulder, when we are doing, what all structures should we focus on? Hello, ma'am. I think
You are able to hear my
I'm able to hear your voice.
me clearly? Okay.
Very clear.
So
very clear.
dynamic evaluation is very important, especially when you have the impingement. So you ask the patient, you keep your probe at the AC joint and move acromion at the acromion, and then ask the patient to abduct slowly. So you will definitely see the movement of your supraspinatus going below the acromion, and that will tell you whether it is the smooth gliding movement of the supraspinatus below the acromion, or there is a restriction. So that is one of the way for seeing the dynamic evaluation for the supraspinatus for the impingement.
So I think those were the questions. And one update for the Yeah, okay. One more is
Hi,
there. Good.
Dr. Javed.
Yes, sir. Yes, sir.
Hi, ma'am. Hi, sir. Madhan, sir.
Hi,
Pratibha, ma'am.
Vikar.
Hi, ma'am. How are you, ma'am?
I'm
Wonderful
good.
presentation. Wonderful presentation by both of you. Just to add on to what Madam told, the dynamic testing in the anterior side, we can also add on where our coracoid is there. We can keep it, and the superficial and deeper layers of your subscapularis can be appreciated very well. The deeper layers of the subscapularis actually become, as they go deep, become a part of the joint capsule which attaches to the anterior labrum. Certain times there can be tears at these levels also, which only can be picked up with dynamic examination. So the two layers of your subscapularis, which can only be appreciated very well, and your subcoracoid bursa.
Right.
Without dynamic testing, and many a times it can be missed out even on MRI, as Madam told very rightly. That is the
Yeah,
biggest
you
tool,
can
I
even
believe.
do the dynamic evaluation for the adhesive capsulitis.
Yeah.
Correct.
Even that is
Same.
possible.
At that same location where Madam has told, the external rotation and internal rotation can both be, because there will be joint restriction at that time. So you can compare and see with the opposite side. Dynamic testing helps you in that because of adhesive capsulitis. Thank you.
Thank you very much, sir, for your inputs. We have a few more questions, ma'am, to you. One question
Yeah.
is, will shoulder pathology cause myofascial pain of the trapezius muscle?
In shoulder pathology, will shoulder pathology
Will a shoulder
cause?
pathology
So
lead to
we just saw the stepwise approach. Say one of the causes for the shoulder pain, which could be confused, is the extraglenohumeral. So that is not extraglenohumeral, the extrinsic cause. The extrinsic cause is, and one of the most common cause which could be confused is the neck pain and the myofascial pain. So nowadays, because this text neck syndrome and the sedentary lifestyle and more use of gadgets, with all that, we come across so many cases of trapezius, the levator scapulae. There is an myofascial component which is arising from these muscles. So definitely this could mimic like a shoulder pain, and you have to definitely, you could go for a good physiotherapy, trigger point injections, dry needling, definitely will resolve the pain if it is arising from the myofascial component.
We have one more question, ma'am. Dr. Milan is asking, he has a patient with scapular fracture 1 month ago. Surgery has not been done. There is shoulder pain. He asks, will a suprascapular nerve block help?
If I think it definitely needs an evaluation with an orthopedician first. And in case if the patient has already done and everything has been done and the patient has come to you only for pain management, then definitely the suprascapular nerve block will help.
So one update for the participants. I'll just start sharing my screen. So thank you very much for joining today's webinar. This was from the ALGOS Academy of Medicine. And in this academy, we have a list of courses. One being the preparatory courses for the examinations, that is the FIPP examination preparatory course, and the EDPM preparatory course, both for FIC as well as the ESRA EDPM. We have courses for part 1 and part 2. And for the undergraduate and postgraduate levels, we have fundamentals in pain medicine basic course and anesthesia exam preparatory course as well. And I'm very happy to announce that we will be conducting our MSK ultrasound hands-on workshop on 28th of April, that is this Sunday. And our esteemed faculties would be Dr. Pratibha ma'am, who is there with us, wherein ma'am gave us the diagnostic protocols for shoulder, and we will be learning the hands-on interventions and everything on Sundays in the workshop. We also have Dr. Vikar Ahmed and Dr. Satish Kumar as well with us, our other esteemed faculties. So before I conclude, I want to extend my thanks to Dr. Madhan Pandian sir and Dr. Pratibha Matche ma'am for accepting the kind invitation And I think there is one last question, ma'am, if I can just take this with you. So there is a question wherein they have asked, there's a young patient post-stroke having stiffness in the shoulder, stiffness in the wrist and elbow too. Physiotherapy is ongoing. What intervention can be done to release the stiffness? Stiffness in
Yeah,
shoulder.
to release the stiffness, definitely rehabilitation only is the solution. We cannot release the stiffness. But you can facilitate rehabilitation by giving a suprascapular block. That I can say. That if it is a shoulder pain, that's what I was telling, that we get a lot of cases from the PMR department, and we have a protocol set that we put a suprascapular catheter for a week, and round the clock every 8 hourly we give 6 ml of 0.25% bupivacaine, because when the rehabilitation is being done, they will have a lot of pain. So if you give even just before rehabilitation and even after rehabilitation, because they will be doing regularly these exercises. So it will help them, which will have a good experience for them, the pain relief, as well as it will facilitate, it will make the rehabilitation fast track.
Very true. So I'd like to extend my thanks to our esteemed faculties on a Sunday morning. Thank you very much for sparing time, taking your time and accepting our kind invitation. Dr. Pratibha Matche ma'am, Dr. Madhan Pandian sir, thank you very much. Thank you for the participants as well for joining in on a Sunday morning. Almost 55 to 60 participants I could see. And this is all testimony to the enthusiasm of pain medicine, which is far spreading and which is very heartening to see in our field. Thank you very much.
Sir.
Sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you so much, Javed, and thank you,
Thank you, ma'am.
everybody.
Thanks, speaker.
Yeah.
Thank you.
Okay, and before I conclude, I'd like to tell everyone this meeting is being recorded, and soon I will be uploading it in the social media profiles and even on our YouTube channel. So those who have missed can watch the entire meeting once it has been uploaded. Thank you very much. And the next webinar I will be announcing soon. So stay tuned. Thank you very much. Good day.
Okay.
Thank you, Dr. Javed. Thank
Have
you.
a good Sunday.
Thank you.
Thank you all.